Hey, welcome to today's video. Today's topic of discussion is ascites. We have discussed abdominal swelling in the previous video, and source of this video is from Harrison, and this video is intended for medical students. So ascites is nothing but accumulation of fluid in abdomen. To be more specific, accumulation of fluid in the peritoneal cavity is called as ascites. Coming to pathogenesis of ascites, so pathogenesis of ascites in presence of cirrhosis of liver is different and in absence of cirrhosis of liver is different. Most of the times, that is 84% of the time, ascites is due to cirrhosis of liver. So we need to understand the pathogenesis in cirrhosis of liver, and we will be discussing detailedly about the pathogenesis of ascites in presence of cirrhosis of liver. Ascites in patient with cirrhosis is result of portal hypertension and renal salt and water retention. So, ascites in patients with cirrhosis is result of portal hypertension and renal salt and water retention. We'll be expanding these lines further in the video. Before we go into the topic, we should understand something called as Ohm's law. According to Ohm's law, pressure is the product of resistance and flow. If you see this slide, so Q is blood flow, delta P is change in pressure, R is resistance of vessel. When there is vasoconstriction, that is reduction in radius, there is increase in resistance and decrease in blood flow. But when there is vasodilation, that is increase in radius, there is decrease in resistance and increase in blood flow. So before we dive into the topic, we need to understand this so that the further understanding of the topic is easier. So first step is the development of hepatic fibrosis. The hepatic fibrosis development will disrupt the normal architecture of the hepatic sinusoids and impedes normal blood flow through the liver. When I say impedes, it reduces the normal blood flow through the liver. Second step is activation of hepatic stellate cells, which mediate fibrogenesis, lead to smooth muscle contraction and fibrosis. Finally, cirrhosis is associated with decrease in the endothelial nitric oxide synthase production and increased hepatic vasoconstriction. When there is reduction of nitric oxide, there is vasoconstriction. There is increased vasoconstriction. When there is increase in nitric oxide, there is increased vasodilation. So in cirrhosis, there is decreased endothelial nitric oxide synthase production, which lead to increased hepatic vasoconstriction. If you see this slide, again to understand for better understanding, there's a slide of splanchnic circulation here. So you can see there is inferior vena cava, hepatic veins, liver, portal vein, and the blood supply from the aorta, celiac artery, superior mesenteric artery, and inferior mesenteric artery. So when there are architectural disturbances such as fibrosis, scarring, and vascular thrombosis, or functional alterations such as contraction of vascular smooth muscle and stellate cells, there is increased hepatic resistance, which lead to portal hypertension and further splanchnic vasodilatation. You see in this, if there is increased hepatic resistance here, of course there's pooling of blood in the portal vein, so which will lead to portal hypertension and further will cause splanchnic vasodilatation. So development of cirrhosis is associated with increased systemic circulating levels of nitric oxide. You should remember that the nitric oxide levels in the systemic circulation are increased, whereas in hepatic it is decreased, so it causes vasoconstriction. Whereas systemic, these levels are increased, which will lead to vasodilatation. Increased levels of vascular endothelial growth factor and increased levels of tumor necrosis factor, all these three will result in splanchnic arterial vasodilatation. So vasodilatation of splanchnic circulation results in pooling of blood and a decrease in effective circulating volume, which is perceived by the kidneys as hypovolemia. This will result in compensatory vasoconstriction via release of antidiuretic hormone. Antidiuretic hormone will lead to free water retention and activation of sympathetic nervous system and the renin angiotensin aldosterone system. which will lead to renal sodium and water retention. So if you see this image here, when there is increased hepatic resistance, there is pooling of blood in portal veins, which will lead to portal hypertension. Portal hypertension, because of portal hypertension, there is release of nitric oxide in systemic circulation, which will cause systemic vasodilatation. If you see this image from osmosis, when there is release of nitric oxide from the endothelial cells, the arteries dilate and this causes decreased blood pressure. This decreased blood pressure will further causes release of aldosterone. Aldosterone release will cause kidneys to retain sodium and water. Because of retention of water, further this fluid is pushed across the tissues and into the peritoneal cavity, which will cause ascites. And if there is invasion of bacteria, which will lead to bacterial peritonitis. So when there's systemic vasodilatation, activation of renin-angiotensin-aldosterone system will cause ascites, and antidiuretic hormone will cause hyponatremia, and whereas sympathetic nervous system activation will cause hepatorenal syndrome. We'll further understand this topic through this slide from Calgary Guide, and this will be like summary of the whole topic which we were speaking till now. Before we dive into this topic, we need to understand two things. That is, one is hydrostatic force and the other one is oncotic force. Hydrostatic force is the force by which the blood is pushed away from the blood vessel to the periphery, whereas oncotic force is the force by which the blood is pushed from the periphery to the blood vessel. With this basic understanding, we'll further dive into this final slide from Calgary Guide. So when there is cirrhosis of liver, that is cirrhotic liver, there is decreased synthesis of albumin. When there is decreased albumin concentration in blood, this albumin normally contributes to oncotic pressure. So there is decrease in oncotic pressure. Till here, you should understand there is decrease of oncotic pressure. We'll go through the other mechanism. When there is intrahepatic fibrosis, this causes liver-bound blood to back up in portal vein, which will lead to portal hypertension and release of vasodilators such as nitric oxide from the portal vein endothelium. That is, in systemic circulation of vasodilators such as nitric oxide occurs. This will lead to vasodilatation and reduction in systemic blood pressure. Reduction in systemic blood pressure will activate baroreceptors in the kidney, which will sense as reduction of blood pressure and activation of renin-angiotensin-aldosterone system. So this will cause kidneys to reabsorb more sodium and increase plasma sodium levels. So water will always follow sodium into the plasma by osmosis. So fluid retention increases hydrostatic pressure. So there is reduction in oncotic pressure here and increase in hydrostatic pressure. When there is reduction of systemic blood pressure, lower blood pressure acting on vascular baroreceptors plus other poorly understood factors lead to ADH secretion from posterior pituitary, which will result in increased antidiuretic hormone secretion, and ADH makes collecting ducts in the kidney more permeable to water, further water absorption. When there is increased free water more than sodium, this will dilute sodium in serum and causes hyponatremia. So until here we understood that there is increase in hydrostatic pressure and more than oncotic pressure in the blood. Because of this, there is plasma extravasation into the peritoneal cavity, which is called as ascites. So ascites is accumulation of serous fluid in the peritoneum. How can you examine this? So one is bulging of flanks. So you can see that there is bulging of flanks, that is fluid in the abdomen causes sides to bulge when lying down. And the other test would be positive shifting dullness test. There is tympani on percussion when the patient lying on side due to ascitic fluid that follows gravity to the contralateral side. If you see this, so here there is tympani and there is dull note here. So positive fluid wave test is another thing where tapping patient's side will cause fluid wave to travel to the contralateral side, patient in supine position. I hope it is clear. The pathogenesis due to cirrhosis of liver is very important, and I think we have re-emphasized it in a very clear way. And if you need to get download this slide, it is from the Calgary Guide. You can download this slide from the www.thecalgaryguide.com. So diving further into the topic, pathogenesis in the absence of cirrhosis. Ascites in the absence of cirrhosis generally results from peritoneal carcinomatosis, peritoneal infection, or pancreatic disease. So how does peritoneal carcinomatosis cause ascites? The tumor cells lining the peritoneum produce a protein-rich fluid that contributes to the development of ascites. Whereas when there is infection, the tubercles deposited on the peritoneum exude a protease fluid which will cause ascites. Accumulation of fluid in the peritoneal cavity and further cause ascites. So the last thing is pancreatic ascites, which is resulting from leakage of pancreatic enzymes into the peritoneum. So, further understanding the causes of ascites, as I mentioned earlier, cirrhosis accounts for 84% of cases of ascites. Other causes include cardiac ascites, peritoneal carcinomatosis, and mixed ascites, which is resulting from cirrhosis and a second disease, accounting for 10 to 15% of cases. Less common causes of ascites include massive hepatic metastasis, infections such as tuberculosis or chlamydia infection, pancreatitis, and renal disease such as nephrotic syndrome. There are some rare causes of ascites which include hypothyroidism and familial Mediterranean fever. Coming to understanding the etiology of ascites, it is best determined by paracentesis, that is removal of ascitic fluid from the peritoneal cavity. The ideal position would be the left lower quadrant is preferred because of the greater depth of ascites and the thinner abdominal wall. The rare complications of paracentesis include abdominal wall hematomas, hypotension, and hepatorenal syndrome and infections. So this would be the left lower quadrant, and this image is from the internet, I think from Ambos. So if the color of the fluid is chylous, it is mostly because of lymph disorders. If it is bloody, it is because of the trauma. If it is dark brown, it occurs in biliary tract perforation. If it is black, it is seen in pancreatic necrosis. Again, it is very important to measure SAG. What is SAG? We'll be discussing further. It is serum albumin minus ascites albumin. Again, discussing about turbid fluid, if the tap or paracentesis, after the paracentesis, if the fluid is turbid, it suggests there is presence of infection or tumor cells. Again, as we discussed, if it is white, milky fluid, it indicates that triglyceride level is more than 200 milligram per deciliter and often more than 1000 milligram per deciliter. It is an hallmark of chylous ascites. Result from disrupt, disruption of the lymphatic system, right? Lymphatic disruption that may occur with trauma, cirrhosis, tumor, tuberculosis, or certain congenital abnormalities. And dark brown fluid, as we have discussed, can reflect a high bilirubin concentration and indicates biliary tract perforation. Coming to the last color, that is black fluid. Black fluid may indicate the presence of pancreatic necrosis or metastatic melanoma. This image shows how the tap is done. First, you have to stretch the skin 1 to 2 centimeters opposite side and then insert the needle. It is called Z technique, right? The third thing is withdraw the ascitic fluid for analysis, then remove the needle and allow subcutaneous tissue to retract to its original position so that the needle tract and the ascitic fluid tract are separated, so there is no leakage. Coming to diagnostic paracentesis, you will send the ascitic fluid for the analysis of SAG ratio. So ascitic fluid should always be sent for measurement of albumin, total protein level, cell count, and differential count. And if infection is suspected, you should also send for gram stain and culture with inoculation into blood culture bottles at patient's bedside. A serum albumin level should also be measured simultaneously. To calculate the SAG, you should always take simultaneously serum albumin and ascitic albumin. So it was easy to calculate serum ascites albumin gradient, that is SAG ratio. SAG ratio is calculated by subtracting serum albumin minus, you can see here, serum albumin minus ascites albumin. So again, coming to the final phase of this topic, SAG, serum ascites albumin gradient or serum albumin ascites gradient, if it is more than 1.1, it reflects the presence of portal hypertension. and indicates that ascites is due to increased pressure in the hepatic sinusoids. Whereas if it is less than 1.1, it indicates that the ascites is not related to portal hypertension, as in tuberculous peritonitis or peritoneal carcinomatosis or pancreatic ascites. This picture is from Harrison. Again, it will differentiate if the SAG is more than 1.1 and less than 1.1. If it is more than 1.1 gram per deciliter, definitely it is because of portal hypertension, and you calculate ascites protein and ascitic protein if it is less than 2.5 and more than 2.5. If it is less than 2.5 gram per deciliter, the most common cause is cirrhosis, and if there is late Budd-Chiari syndrome and massive liver metastasis. If it is more than or equal to 2.5, it might be secondary to hepatic failure, constrictive pericarditis, early Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. Coming to less than 1.1, it is due to biliary leak, nephrotic syndrome, pancreatitis, peritoneal carcinomatosis, and tuberculosis. So SAG is useful for distinguishing ascites caused by portal hypertension from non-portal hypertension ascites. The SAG is calculated by subtracting the ascitic albumin concentration from serum albumin level and does not change with diuresis. So pro-BNP will also be useful if the ascites is secondary to heart failure. So this pro-BNP is released by the heart as a result of increased volume and ventricular wall stretch. High levels are usually seen in heart failure. Brain natriuretic peptide levels are high usually in heart failure. That's all from today's topic. Thank you so much.